The lymphatic system. Q&A. Welcome to today's podcast, where we discuss the main surgical aspects of the lymphatic system. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the management of lymphatic disorders. Pause the podcast after each question to attempt answer. Let's begin. Embryology and anatomy question. When does the development of the lymphatic system begin, and where do the initial lymph sacs form? Answer. The development of the lymphatic system begins during the 6th week of embryogenesis, with the formation of lymph sacs near the jugular veins. Question. At what stage does the cisterna chyli develop, and where is it located? Answer. The cisterna chyli forms during the 8th week of development and is situated just dorsal to the aorta. Question. How does the thoracic duct develop embryologically? Answer. The thoracic duct arises from communicating channels that connect the lymph sacs, and these channels develop during the 9th week of embryogenesis. Question. What is the role of endothelial buds in the formation of the peripheral lymphatic plexus? Answer. Endothelial buds originating from the primordial lymphatic system proliferate alongside the developing venous system, resulting in the formation of the peripheral lymphatic plexus. Question. What are the consequences of improper connection between lymphatic sacs and the lymphatic or venous systems? Answer. Failure of the lymphatic sacs to properly connect with the lymphatic and venous systems can lead to the formation of focal lymphatic cysts, known as cavernous lymphangiomas, or cystic lymphatic lesions, referred to as simple capillary lymphangiomas. Question. How does hypoplasia or failure of lymphatic drainage channels contribute to disease? Answer. Hypoplasia or failure of the drainage channels that connect the lymphatic systems of the extremities to the main lymphatic system can result in primary lymphedema. Question. Which molecular factors regulate lymphangiogenesis? Answer. Lymphangiogenesis is regulated by vascular endothelial growth factor C, vascular endothelial growth factor D, vascular endothelial growth factor receptor 3, and neuropilin 2. Question. Which genetic mutations are associated with hereditary lymphatic disorders? Answer. Mutations in the FOXC2 gene are linked to hereditary lymphedema, whereas mutations in the SOX18 gene are associated with hypertrichosis lymphedema telangiectasia. Question. What is the role of receptor activity modifying protein 1 in lymphangiogenesis, and what is observed in knockout models? Answer. Receptor activity modifying protein 1 influences lymphangiogenesis, and knockout mice lacking this protein exhibit increased surgery-associated lymphedema due to enhanced recruitment of pro-inflammatory macrophages. Function and structure question. What are the main components of the lymphatic system? Answer. The lymphatic system comprises lymphatic capillaries, collecting vessels, and lymph nodes. Question. What is the primary function of lymphatic capillaries? Answer. Lymphatic capillaries are responsible for absorbing lymph from the interstitial spaces. Question. What is the main function of lymph nodes within the lymphatic system? Answer. Lymph nodes filter lymph and play a crucial role in the immune response by presenting antigens. Question. What structural features contribute to the high porosity of lymphatic vessels? Answer. Lymphatic vessels are highly porous due to the presence of few tight junctions, a limited basement membrane, and anchoring filaments. Question. How does the structure of lymphatic vessels facilitate their function? Answer. The structural characteristics of lymphatic vessels allow for the influx of interstitial fluid, macromolecules, cells, and microbes into the lymphatic channels. Question. How is lymph drained from tissues into the venous system? Answer. Collecting lymphatic vessels drain into the main lymphatic channels, which ultimately empty their contents into the venous system. Question. What are the primary functions of the lymphatic system? Answer. The lymphatic system reabsorbs tissue fluid and macromolecules, presents antigens to lymph nodes to initiate immune responses, and transports fat from the gastrointestinal tract. Question. How do lymph nodes contribute to the immune system? Answer. Lymph nodes act as the first line of defense in the immune system by presenting antigens, immune cells, microbes, and mutant cells for immunologic processing. Question. What is the role of the lymphatic system in fat transport? Answer. Lymphatic vessels are essential for the absorption and transport of fats, and they may also play a role in the transport and regulation of lipids within peripheral tissues. Question. What mechanisms drive lymph transport within lymphatic vessels? Answer. Lymph transport is primarily driven by the intrinsic contractility of lymphatic vessels, which is facilitated by valves that ensure unidirectional flow. Question: what secondary factors assist lymph flow, especially during periods of stasis? Answer: lymph flow is aided by surrounding muscle activity, breathing, and arterial pulsations, particularly when the primary mechanisms are insufficient. Question: how does lymph transport differ from venous flow? Answer: unlike venous flow, which heavily relies on external factors such as muscle contraction, lymph transport depends more on the contractility of the lymphatic vessels themselves. Pathophysiology and staging. Question: what causes lymphedema? Answer: lymphedema results from the inability of the lymphatic system to adequately manage the accumulation of protein and fluid in the tissues. Question: what are the types of lymphatic system impairment? Answer: impairment of the lymphatic vasculature may present as aplasia, absence of lymphatic vessels, hypoplasia, reduced number of lymphatic vessels, or hyperplasia, excessive but incompetent and tortuous vessels. Question: how common is hyperplasia as a cause of lymphedema? Answer: hyperplasia accounts for approximately 8% of lymphedema cases. Question: what clinical staging system is used for lymphedema? Answer: an international working group has established a clinical staging system for lymphedema, which categorizes the condition based on severity and tissue changes. Question: what are the stages of lymphedema according to this system? Answer: the stages include a latent phase, grade 0, with no clinical edema, stage 1 with soft pitting edema, stage 2 with more pronounced, non-pitting, and spongy edema, and stage 3 with irreversible edema, severe skin changes, and excessive subcutaneous fibrosis due to local inflammation and recurrent infections. Question: what tissue changes are characteristic of stage 2 lymphedema? Answer: stage 2 lymphedema is characterized by an accumulation of fibroblasts, adipocytes, and macrophages, leading to inflammation and structural changes in the skin and subcutaneous tissue. Question: what are the hallmarks of stage 3 lymphedema? Answer: stage 3 lymphedema is distinguished by irreversible edema, severe changes in the skin, and marked subcutaneous fibrosis. Question: what factors contribute to tissue damage in lymphedema? Answer: tissue damage in lymphedema results from local inflammation, recurrent infections, and injury to the lymphatic channels. Differential diagnosis. Question: what are the typical physical examination findings in patients with lymphedema? Answer: physical findings include a firm, hardened consistency of the affected tissue, loss of normal contour around the ankles, known as the tree trunk pattern, swelling of the dorsum of the foot, referred to as buffalo hump, and thickened, squared toes, stemmer sign. Question: what skin changes are commonly observed in lymphedema? Answer: the skin may exhibit lichenification, a peau-d'orange appearance, and hyperkeratosis. Question: what aspects of medical history are relevant in lymphedema assessment? Answer: a history of recurrent cellulitis, lymphangitis, and fungal infections is relevant, as well as noting that the swelling does not significantly improve with overnight elevation. Question: what are common causes of bilateral edema? Answer: bilateral edema is often due to systemic conditions such as cardiac failure, renal failure, or hypoproteinemia. Question: how does lipedema typically present? Answer: lipedema presents as bilateral, non-pitting edema of the legs, typically sparing the feet, and is often familial and lifelong in duration. Question: what is the recommended initial approach to evaluating suspected lymphedema? Answer: the initial evaluation should include a detailed medical history and thorough physical examination. Question: what is the most common cause of unilateral leg edema? Answer: venous disease is the most common cause of unilateral leg edema. Question: how does venous edema differ from lymphedema in clinical characteristics? Answer: venous edema is typically pitting, most pronounced in the legs and ankles, improves with leg elevation, and is manageable with compression therapy. Question: what are the signs of advanced venous insufficiency? Answer: advanced venous insufficiency may present with skin atrophy, brawny pigmentation, and ulcers located above, behind, or beneath the malleoli. Classification. Question: how is lymphedema classified? Answer: lymphedema is classified as either primary, with no identifiable cause, or secondary, which results from a known disease or disorder. Question: what are the types of primary lymphedema based on age of onset? Answer: primary lymphedema includes congenital, onset before 1 year of age, lymphedema precox, Onset between 1 and 35 years. And lymphedema tarda. Onset after 35 years. Question. What is the most common cause of secondary lymphedema worldwide? Answer. The most common cause of secondary lymphedema globally is filariasis, an infection caused by the parasite Wuchereria bancrofti. Question. What is the most prevalent form of lymphedema overall? Answer. Acquired or secondary lymphedema is the most prevalent form overall. Question. What are common causes of secondary lymphedema in developed countries? Answer. In developed countries, common causes include surgery, radiation therapy, tumor invasion, direct trauma, or infection. Question. What is the incidence of lymphedema following breast cancer treatment involving axillary intervention? Answer. Up to 30% of patients undergoing axillary intervention for breast cancer will experience clinically significant lymphedema. Diagnostic tests. Question. How does the ease of diagnosing lymphedema vary with disease stage? Answer. Diagnosis of lymphedema is straightforward in advanced stages but can be challenging in early stages when edema is mild and pitting. Question. What imaging modalities are important for evaluating secondary lymphedema? Answer. Computed tomography and magnetic resonance imaging are essential for excluding underlying oncologic conditions in cases of secondary lymphedema. Question. What is the diagnostic test of choice for suspected primary lymphedema? Answer. Lymphoscintigraphy is the preferred diagnostic test for suspected primary lymphedema with delayed lymphatic drainage. Question. How does lymphoscintigraphy assist in the diagnosis of lymphedema? Answer. Lymphoscintigraphy assesses lymphatic function and helps distinguish lymphedema from other causes of limb swelling. Question. What is the procedure and advantage of lymphoscintigraphy? Answer. The procedure involves the injection of a small amount of radioactive tracer, followed by monitoring its migration with a gamma camera. It is simple, safe, reproducible, and involves minimal radiation exposure. Question. What are the diagnostic criteria for lymphedema based on lymphoscintigraphy uptake values? Answer. An uptake value of less than 0.3% at 30 minutes is diagnostic of lymphedema, while normal uptake ranges from 0.6% to 1.6%. Question. What is the traditional invasive procedure for lymphatic imaging, and when is it used? Answer. The traditional procedure involves cannulation of the lymphatics at the forefoot and injection of contrast medium. It is invasive, tedious, requires magnification optics and anesthesia, and is infrequently used for preoperative evaluation in patients undergoing direct lymphatic vessel surgery. Question. What new imaging test is promising for visualizing lymphatic vessels and nodes in lymphodematous limbs? Answer. Contrast magnetic resonance lymphangiography, performed after injection of gadobenate dimeglumine, is promising for visualizing lymphatic vessel and node anatomy and function in affected limbs. Question. How is early lymphedema detected with bioimpedance spectroscopy? Answer. Bioimpedance spectroscopy detects early lymphedema by measuring the flow of electrical current, which is inversely related to tissue fluid, and has demonstrated high sensitivity and specificity in small studies. Question. How are technological advances improving lymphatic imaging? Answer. Advances in technology and the development of new contrast agents are enhancing the diagnostic accuracy of lymphatic imaging. Question. What roles do machine learning and artificial intelligence play in lymphedema assessment? Answer. Machine learning and artificial intelligence are being investigated for computed tomography analysis of lymphedema and may assist in patient screening. Question. How is non-contrast magnetic resonance lymphangiography used in surgical planning? Answer. Non-contrast magnetic resonance lymphangiography is increasingly utilized as a non-invasive alternative to conventional lymphangiography for imaging lymphatics during surgical planning. Therapy. Question. What are the mainstays of conservative lymphedema treatment? Answer. Conservative therapy includes limb elevation, use of compression garments, complex decongestive physical therapy, and pneumatic compression pump therapy. Question. Are there effective medications for lymphedema management? Answer. Currently, there are no effective medications available for the treatment of lymphedema. Question. When is surgical intervention considered in lymphedema treatment? Answer. Surgical intervention is considered for advanced cases that do not respond to non-operative measures. General therapeutic measures. Question. What skincare recommendations should be given to patients with lymphedema? Answer. Patients should receive education on meticulous skincare and strategies to avoid injuries. Question. How should infections in lymphedema be managed? Answer. Prompt medical attention is essential for signs of infection, as these can progress rapidly. Appropriate antibiotic therapy should be initiated without delay. Question. What additional management strategies benefit lymphedema patients? Answer. Treatment of eczema, performing range of motion exercises, and maintaining an ideal body weight are all beneficial for lymphedema management. Elevation and compression garments. Question. When are compression garments indicated for lymphedema patients? Answer. Compression garments are essential for lymphedema patients at all stages, except when the legs are elevated above the level of the heart. Question. What are the characteristics of the ideal compression garment for lymphedema? Answer. The ideal compression garment is custom-fitted, exerts a pressure of 30 to 60 mm of mercury, and provides protection from injuries. Question. What additional recommendations should be provided to lymphedema patients regarding activity and limb elevation? Answer. Patients should avoid prolonged standing and should elevate their legs at night by supporting the foot of the bed with 15 cm blocks. Complete decongestive physical therapy. Question. What is the primary goal of complete decongestive physical therapy in lymphedema? Answer. The goal is to reduce lymphedema by stimulating lymphatic vessels, breaking down fibrous tissue, and redirecting lymph fluid flow. Question. How is complete decongestive therapy performed? Answer. Therapy begins on the unaffected side, then proceeds to the affected limb, using massage from proximal to distal regions. Question. How are therapy outcomes maintained following decongestive treatment? Answer. Reduction in lymphedema volume is maintained with low stretch wrapping and custom compression garments. Question. Is complete decongestive physical therapy appropriate for all stages of lymphedema? Answer. Yes. This therapy is suitable for all stages of lymphedema. Question. What is the recommended initial treatment regimen for lymphedema with physical therapy? Answer. The initial regimen consists of daily to weekly massage sessions over 8 to 12 weeks, combined with limb elevation and elastic compression stockings. Question. What is the maintenance strategy following initial decongestive therapy? Answer. Maintenance involves regular massage treatments every 2 to 3 months and continuous use of compression garments. Question. Is manual lymphatic drainage recommended for all lymphedema patients? Answer. Yes. Manual lymphatic drainage is recommended for all patients with lymphedema, including those in the early stages. Question. What degree of volume reduction is generally achieved with compliant lymphedema patients? Answer. A volume reduction of 60 to 70% is generally achieved, with compliant patients retaining 90% of this reduction. Question. Why is lifelong maintenance important in lymphedema management? Answer. Lifelong maintenance is crucial to sustain the reduction in limb volume and prevent recurrence of symptoms. Compression pump therapy. Question. How does pneumatic compression pump therapy work in lymphedema management? Answer. Pneumatic compression pump therapy uses a sleeve with inflatable compartments that sequentially inflate to mimic manual massage, helping to move stagnant fluid out of the affected limb. Question. What is the initial treatment protocol for lymphedema using compression pump therapy? Answer. Initial treatment involves hospitalization for 3 to 4 days, limb elevation, physical therapy, and repeated compression pump sessions. Question. What precautions should be taken when using compression therapy in patients with cardiac or renal dysfunction? Answer. Such patients require careful monitoring to prevent fluid overload during compression therapy. Question. What is the long-term maintenance plan following compression pump therapy? Answer. Long-term maintenance includes the use of high-quality compression garments and periodic maintenance therapy sessions as needed. Drug therapy. Question. What are benzopirones, and what is their proposed mechanism in lymphedema treatment? Answer. Benzopirones, including coumarin, are compounds thought to reduce lymphedema by stimulating proteolysis and enhancing lymphatic function. Question. What have clinical trials revealed about the efficacy of coumarin in lymphedema treatment? Answer. A trial conducted in 1993 suggested that coumarin was effective in reducing lymphedema symptoms, but a subsequent trial in 1999 found it ineffective for women with lymphedema following breast cancer treatment. Question. What is the current recommendation regarding the use of coumarins for lymphedema? Answer. Due to conflicting evidence from clinical trials, coumarins are not currently recommended for the treatment of lymphedema. Question. What is the effect of diuretics on lymphedema? Answer. Diuretics may temporarily reduce swelling in stage 1 lymphedema but offer no long-term benefit and are not indicated for lymphedema treatment at any stage. Molecular lymphangiogenesis question. How have recent discoveries in lymphatic development influenced potential lymphedema treatments? Answer. Fundamental insights into lymphatic development have identified new therapeutic targets, such as the activation of the vascular endothelial growth factor receptor 3 pathway using vascular endothelial growth factor C and vascular endothelial growth factor D. Question. What is the current status of molecular therapies for lymphedema? Answer. While these therapies have shown promise in animal models, clinical trials are required to determine their therapeutic potential and assess possible side effects in humans. Operative treatment question. What proportion of lymphedema patients can be managed without surgery? Answer. Approximately 95% of lymphedema patients can be managed with non-operative measures. Question. In which patients is surgical intervention for lymphedema considered? Answer. Surgery is considered for patients with stage 2 or stage 3 lymphedema who experience severe functional impairment, recurrent lymphangitis, or severe pain despite optimal medical management. Question. What are the main categories of surgical options for lymphedema? Answer. Surgical options are divided into reconstructive procedures and excisional procedures. Question. Who are suitable candidates for reconstructive surgery in lymphedema? Answer. Candidates are those with proximal obstruction of extremity lymphatic circulation but preserved, dilated lymphatic vessels distal to the obstruction. Question. What are the techniques used in reconstructive lymphatic surgery? Answer. Techniques include anastomosing dilated lymphatics to nearby veins or transposing healthy lymphatic channels to restore drainage. Question. What is the success rate of reconstructive lymphatic surgery? Answer. Objective improvement is achieved in 30 to 80% of patients, with an average initial reduction in excess limb volume of 30 to 84%. Question. What is involved in lymph node transplantation for lymphedema? Answer. The procedure involves harvesting gastroepiploic omental lymph nodes, quantifying lymph nodes, performing microvascular anastomosis in the affected extremity, and possibly debulking lipectomy. Question. What outcomes are expected following lymph node transplantation? Answer. Improvement in limb size and overall quality of life is observed. Question. When are excisional operations indicated for lymphedema? Answer. Excisional operations are indicated when there are no suitable lymphatics for reconstruction, particularly in patients with moderate edema and healthy skin in stages 2 and early 3 lymphedema. Question. What does an excisional operation for lymphedema entail? Answer. The operation involves removal of large segments of lymphodematous subcutaneous tissue and overlying skin, often performed in 2 stages. Question. What are the outcomes of excisional surgery for lymphedema? Answer. 80% of patients experience significant and lasting reduction in limb size, improved function, and better limb contour. Question. What is the minimally invasive Contoulian procedure, and what is its role? Answer. The minimally invasive Contoulian procedure is gaining support as a treatment for advanced lymphedema. Question. What is the role of liposuction in lymphedema management? Answer. Liposuction is a safe and effective technique for short-term control of disabling lymphedema symptoms and is recommended after initial conservative treatment for excess volume removal. Question. What is the Charles operation, and when is it used? Answer. The Charles operation is a classic excisional surgery for severe lymphedema, involving removal of skin, subcutaneous tissue, and deep fascia. Question. What are the outcomes and complications associated with the Charles operation? Answer. The operation provides immediate reduction in limb volume and circumference but carries risks of unpredictable healing and complications such as wound infection, hematoma, necrosis, graft failure, recurrent infections, and, in severe cases, amputation. Chylothorax question. What is chylothorax? Answer. Chylothorax is a condition characterized by the accumulation of lymphatic fluid in the pleural space, resulting in a chylous pleural effusion. Question. What are the common causes of chylothorax? Answer. Chylothorax is usually caused by trauma to the thoracic duct, often related to chest surgery, and less commonly by cancer. Question. How is chylothorax diagnosed, and what are the treatment options? Answer. Diagnosis is based on lipoprotein analysis and measuring triglyceride levels in pleural fluid. Treatment options include tube thoracostomy, a medium-chain triglyceride diet, total parenteral nutrition, and therapy with octreotide or somatostatin. Question: how is persistent chylothorax managed after conservative treatment fails? Answer: if chylothorax persists after 1 week of conservative management, an intervention to identify and occlude the thoracic duct leak is warranted. Question: what is the traditional surgical approach for persistent chylothorax? Answer: the standard approach involves video-assisted thoracoscopy or thoracotomy to identify and ligate the thoracic duct above and below the site of leakage. Question: what new endoluminal technique is emerging for managing postoperative chylothorax? Answer: a new endoluminal technique, beginning with lymphangiography and percutaneous access to the cisterna chyli, is becoming the preferred initial approach for managing persistent postoperative chylothorax. Question: what is the success rate of thoracic duct embolization in chylothorax management? Answer: the success rate of thoracic duct embolization exceeds 50% when performed by experienced practitioners. Question: how is cancer-related chylothorax managed? Answer: fluorodesis is highly effective in preventing recurrence of chylothorax associated with malignancy. Chyloparidonium. Question: what are the common causes of chylous ascites in children and adults? Answer: in children, chylous ascites is most often due to congenital lymphatic abnormalities, while in adults, it is commonly associated with malignant disease. Question: how is chyloparidonium diagnosed? Answer: diagnosis is made by identifying the presence of chylomicrons and a triglyceride level above 110 mg per deciliter in acidic fluid. Question: what are the general treatment options for chyloparidonium? Answer: treatment options include paracentesis, a medium-chain triglyceride diet, and total parenteral nutrition. Question: how should persistent postoperative chyloparidonium be managed? Answer: if ascites persists after several weeks of non-operative management, percutaneous embolization or surgical exploration is recommended to address the leak. Question: what are the success rates of conservative management strategies for chyloparidonium? Answer: total parenteral nutrition achieves success in 77 to 100% of cases, a medium-chain triglyceride diet in 75%, and the combination of a medium-chain triglyceride diet with octreotide in 100% of cases. Question: how is the choice of management approach determined in chyloparidonium based on chyle leakage volume? Answer: total parenteral nutrition is suggested for chyle leakage above 200 ml per day, while a medium-chain triglyceride diet is also recommended for such cases. Question: what is the recommended management for congenital chylous ascites? Answer: non-operative management is advised for 4 to 6 weeks. If ascites persists, lymphoscintigraphy or lymphangiography should be performed, followed by surgical intervention to ligate leaking lymphatic vessels or resect affected bowel if necessary. Question: how is malignant chylous ascites managed? Answer: aggressive treatment of the underlying malignancy is indicated, as this typically controls the chyloparidonium. Question: what is the recommended duration for non-operative management of congenital and malignant chylous ascites? Answer: non-operative management should be maintained for 4 to 6 weeks for both congenital and malignant causes. Tumors of the lymphatics. Question: what are lymphangiomas, and how do they compare to hemangiomas? Answer: lymphangiomas are benign tumors of the lymphatic system and are analogous to hemangiomas, which are tumors of blood vessels. Question: what are the main types of lymphangiomas? Answer: the two main types are simple, capillary lymphangiomas and cavernous lymphangiomas, also termed cystic hygromas. Question: where are lymphangiomas most commonly located, and when do they typically present? Answer: most lymphangiomas are present at birth, with 90% identified by the end of the first year. Cavernous lymphangiomas commonly occur in the neck or axilla, while simple lymphangiomas are more frequent in the head, neck, and axilla. Question: are lymphangiomas commonly found within internal organs or connective tissue? Answer: lymphangiomas are rarely located within the trunk, internal organs, or connective tissue. Question: what is the definitive treatment for lymphangiomas? Answer: surgical excision is the standard treatment for lymphangiomas. Question: what surgical considerations are important when excising lymphangiomas? Answer: care must be taken to preserve normal surrounding structures during surgical excision. Question: what is lymphangiosarcoma, also known as Stewart-Treves syndrome? Answer: lymphangiosarcoma, or Stewart-Treves syndrome, is a rare malignant tumor that develops as a complication of long-standing lymphedema. Question: how does lymphangiosarcoma typically present clinically? Answer: it presents with an acute worsening of edema and the appearance of subcutaneous nodules, which may bleed or ulcerate. Question: what is the treatment and prognosis for lymphangiosarcoma? Answer: treatment involves preoperative chemotherapy and radiation followed by surgical excision, but the prognosis is generally poor. Upper extremity lymphedema. Question: what is the prevalence of primary versus secondary upper extremity lymphedema? Answer: primary upper extremity lymphedema is extremely rare, whereas secondary lymphedema, especially that related to breast cancer, is more common. Question: what symptoms are associated with breast cancer-related upper extremity lymphedema? Answer: symptoms include pain, a sensation of heaviness, tightness, reduced range of motion, interference with daily activities, and potential psychological distress. Question: what is the incidence of breast cancer-related lymphedema and the status of diagnostic criteria? Answer: breast cancer-related lymphedema affects approximately 21% of breast cancer patients, but there are no universally accepted diagnostic criteria. Question: what are the risk factors for developing lymphedema following breast cancer treatment? Answer: risk factors include axillary lymph node dissection with removal of many nodes, mastectomy, higher body mass index, a greater number of metastatic nodes, radiation therapy, and an inactive lifestyle. Question: what surgical approaches are used in the treatment of upper extremity lymphedema? Answer: surgical approaches include lymphatic grafting, where thigh lymphatics are transplanted to the upper extremity, and lymphatic bypass procedures, which connect upper extremity lymphatics to the neck, chest, or veins. Question: what research gaps remain in understanding breast cancer-related lymphedema? Answer: despite advances in breast cancer treatment, the exact reasons why some patients develop lymphedema while others do not remain unclear and require further research. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.